coming to orthopedics. So what is osteomyelitis? And this morning we take a little bit of time and go through it using most of these headings from the definition right down to special groups, and then we'll probably summarize what this osteomyelitis condition is all about. So by definition, it's really an infection in bone and the marrow. So bone in isolation, that hard part that you see, it's not that alone that's infected, but even within and the surrounding tissues I'm talking about is not the muscles or the fascia, but certainly the periosteum that's adherent to the bone. Now the periosteum has two layers, that thick fibrous layer, which is structural, and then an inner, more delicate membranous layer. And that membranous layer is where you have new bone being formed. So when you see a periosteal reaction, or you break a bone and you see new bone, the periosteum, but the inner delicate membranous part is what's responsible for the production of that new bone. That's where your osteoblasts will be formed. And it's no different in osteomyelitis if it is affected. And we'll come to that the periosteum is a significant player when it comes to the reaction of infection in and around the bone. This may lead to complete destruction of the bone if it's infected. Over time, with prolonged infection, inflammatory milieu, it weakens the bone. So you lose the structural integrity of the bone, and it can cause weakness with ultimate failure of the mechanical stability of that bone, resulting in pathological fractures. It's a common cause of morbidity in developing countries, as we know, but it's getting better. And one of the reasons for this is the advancement in management, early diagnosis. With respect to epidemiology, the males outdo the females a bit, and it's because of the activities that we're involved in. It's more traumatic, risky behavior, so we end up with all of these injuries. And one of the common causes of osteomyelitis would be open fractures, because we have breached that sterility, that sterile soft tissue envelope which the bone is accustomed to, predisposing the bone now to infection. So before the pre-antibiotic era, the mortality rate was quite alarming, almost 50%. That's like 1 foot in the grave and 1 foot out when you get an infection. You had to worry. Most of these patients, a lot of these patients may actually succumb to an infection in the bone. But we're no longer seeing those high mortality rates. It's very, very, very low. But you still have a significant portion of these patients with chronic morbidity when it comes to infection. But mortality rate has certainly fallen off. At one point in time, 20, 25, 30 years ago, the outpatient department, half of the patients were coming in for infection in the bone, osteomyelitis. But we no longer see those high figures anymore. Why? It's changing. It's a disease that is changing over time, and with the advances in treatment, early diagnosis, the antibiotic therapy that we use now in terms of combination polymicrobial antitherapy, we tend to get a better handle earlier on the disease process so that we can treat them appropriately. And we intervene surgically as needed. And if we can get in and achieve the goals of surgery, then we're one step ahead. It's a win-win situation. When you look at the ethnicity, unfortunately, blacks far more commonly found in blacks over whites, African descent over Caucasians. But the organism is constantly changing. In certain parts of the world, you'd have different organisms causing osteomyelitis. Needless to say that almost every organism under the sun has been implicated in this condition called osteomyelitis. When you culture these organisms, almost everything has been found in the past. So it's not a single entity that's causing it. Of course, nutritional status, the climate, the lifestyle will influence what sort of organisms would commonly cause this condition. And so, from geographical location to geographical location, you may have a changing pattern of the causative agents. Now, if you look at this diagram on the right, you realize that although the tubular bones tend to be more infected than the flat bones, and there are reasons for that. If you look at the diagram, you then realize that the lower limbs account for the majority of this condition. So just the femur and the tibia alone would be 49%. So that's almost half of the cases of osteomyelitis resulting from infection in the lower limbs. So it occurs in the upper limbs, but not as commonly. And in the upper limbs, it's commonly in the humerus. So what then are the risk factors for osteomyelitis? Well, extremes of age for two different reasons, affecting the same thing, of course, and that's the immune system. Now, when you're very young, the child, the immune system is not as mature. It's immature. It's developing. And so when you match them against a healthy young adult, they're relatively immunocompromised. As opposed to the elderly population where the immune system now becomes a bit sluggish and dysfunctional. And again, matching against a young, healthy adult, they're relatively immunocompromised. And so the extremes of age, in the grand scheme of things, they tend to be relatively immunocompromised. And this forms an opportunity. It's an opportunistic environment for the organisms to then infect bone in this population. And so that's a risk factor in and of itself. So the elderly patient and the very young child. Of course, remote sources of infection, so skin sepsis, poor hygiene. You often find this in the patients of lower socioeconomic status. If you're malnourished, then you increase your incidence of poor hygiene, skin sepsis, access to care. You have a prolonged course of an illness because you probably don't have access, or it's very difficult to access immediate medical attention. Trauma, uncontrolled versus controlled. So the uncontrolled trauma would be the motor vehicle accident, the fall from heights, falling from the tree, off the wall, off the roof. And so you end up with open fractures or severely damaged soft tissue envelope, which then predisposes the bone to infection. The controlled trauma that we speak about would be the medical procedures that we undergo. And more, we're doing more and more invasive procedures outside of surgery. So it's not just surgical intervention. Yes, surgery is controlled trauma, but you have the interventional cardiologist who's sticking all sort of things into the heart through small incisions, percutaneous procedures. You have interventional radiologists, the rheumatologists are doing interventional stuff, pulmonologists, physiatrists giving corticosteroid injections into the back, next to the spine. All of this is controlled. But if you have those invasive procedures in and around the bone, if you inoculate, if sterility is breached, if there is seeding, then you can result in osteomyelitis. So it sets up a picture, and therefore you have a risk factor in the controlled trauma. What is common to all of these conditions? Diabetes mellitus, cardiovascular disorders, even the drugs that we use to treat chronic medical illnesses, malignancies, and the medications to treat chemotherapy, cytotoxic agents. Again, comparing to the normal population, you realize that all of these conditions will compromise the immune status, and so they're relatively immunocompromised, thus increasing the risk factor for osteomyelitis. Now, how then do we classify this condition, osteomyelitis? Can anyone suggest a classification that we can use to classify this condition? Now, remember, classifications, if they're going to be of any use, they must achieve at least one or more of the following. So a classification is good if, one, it can influence your management. So if it's not helping you with management, it's probably not that good. If your classification can help you with predicting outcomes and prognoses, then it's important. It's helpful. So management, influence, prognosis, and outcome. The third thing is research purposes. So to standardize a condition or a result, you may want to use a classification. The classification may actually be created just for that specific research paper, but it's still helpful because in collating your data and interpreting and drawing conclusions, a classification may actually help you. It's also a common language among colleagues. So rather than explaining in a half-hour conversation with your colleague on the phone, if you say, I've just seen a patient and I want you to see this patient, as an orthopedic surgeon, you mention, this patient has a Schatzker type 4 injury, and I've ordered some imaging on the knee because I want to know if the vessel is damaged. Now, the minute you say Schatzker, an orthopedic surgeon knows exactly where it is and the type they're dealing with. So already you're engaging your brain into what sort of management this patient may actually benefit from. So classifications help you with a common language among your colleagues. You're not using the classifications to explain anything to your patients, really, because they won't necessarily understand. You must interpret the classification for them and put it into perspective. What is important to them is if they understand what the outcome and the prognosis would be for this type of injury. So the classification has several reasons for its importance. If it's not fulfilling any of these, then it's probably not a good classification. I've said all of this to give you time to tell me what sort of classification then should we use for osteomyelitis. Anybody? So Junella is saying organism that causes it. So if you use a classification like the etiology, causative agent, yes, we're saying that it's always caused by an organism. So how would we then break that down to create a classification if we're using the causative agent, organism? We can use pyogenic versus non-pyogenic, of course. So pyogenic suggests bacterial, which is the commonest type of osteomyelitis. So pyogenic osteomyelitis is by far the commonest. Then everything else would be non-pyogenic. Within non-pyogenic, then you would have viruses, parasites, fungal agents, and those would be subcategories of non-pyogenic. So yes, we can use causative agents, and the commonest, certainly in this neck of the woods, would be Staph aureus. Staphylococcus aureus is the commonest organism. Some cohorts, some subpopulations may have a different organism, but generally speaking, you have Staph aureus, certainly here in Caribbean, Jamaica, is what we see commonly causing osteomyelitis. Taylor said pathogenesis, or the site. Pathogenesis or the site. So I'm not sure. Could you clarify what you mean by pathogenesis site? Is that an anatomical site?
Like, yes, doc, it was two different answers. I was meaning anatomical site for the second answer. And for the first, I was thinking trauma versus being caused by like a skin infection, etc.
Okay, so with respect to pathogenesis, we can look at the mode of transmission. So the mode of transmission would be the classification there. So with mode of transmission, we can look at whether it's hematogenous or is it a direct inoculation? Is it from adjacent tissues? We call that juxtaposed or adjacent. And there are the lymphatics as well. So the lymphatics, although they're tasked with getting rid of infection, if there's a problem with the lymphatics, certainly with venous congestion, you can have the surrounding tissues, including the bone, becoming infected. So hematogenous, which is the most common, yeah, and then the others, less common, but they're modes of transmission. With respect to site, yes, you can use an anatomical classification. So we know the long bone can be separated into different areas. So in development, we know about the epiphysis, metaphysis, diaphysis, and so why not diaphyseal osteomyelitis? Osteomyelitis in the metaphyseal region. Or you can classify it based on the bone. You have long bone osteomyelitis, you have flat bone osteomyelitis, pelvis or calcaneal osteomyelitis, osteomyelitis in the spine. So you have an infective process in the spine itself. So the anatomical classification is also helpful because some of these areas are harder to treat than others. And so it has implications. The other thing is it a weight-bearing bone or not? This has implications because we just said the infection, if it's there long enough, and depending on the virulence of the organism, can weaken the bone. So are we looking at someone who may have an impending fracture or likely to fracture? They may actually present with a fracture in the lower limbs where it's commonly occurring. With respect to the long bone, the commonest area of infection would be your metaphyseal region, the metaphyseal region. So sort of touch base on some of the reasons why it's the metaphyseal region, but the metaphyseal region is what is well liked by the organisms, certainly bacteria. I'm seeing Christina saying acute versus chronic, acute versus chronic. And that is by far the commonest type of classification that we use in orthopedics, although it's probably the most controversial, acute versus chronic. So what we're using here would be the parameters of time, parameters of time. And so with acute and chronic, we can add some other groups. Acute on one end, subacute, somewhere in the middle, chronic, and then you have a category acute on chronic. So this last group suggests that you have infection for a prolonged period of time, but when the patient presents, they give you a much shorter history. And that's because what they're presenting with is an acute manifestation of the infection on the background of chronicity. So there's a smoldering infection and it waxes and wanes. So there are period of quiescence, and so the patient may be asymptomatic, but they have infection. And then there's a dip in probably the immune status, and there's an acute manifestation, swollen, warmth, they may even have a temperature, and then they present with a 2-3 day history, and you're thinking acute presentation, but with chronicity, you see changes on the x-rays that you know did not start 2-3 days ago. So that would be a parameter of time. So we have, based on duration, causative agent, anatomical location, mode of transmission. Let's just dig a little deeper in terms of the classifications. We said all of this already. And the pathophysiology, although we know a lot about it, and it has been around for a long time, it's still not quite defined. And so if you look at hematogenous spread, the commonest type, when it comes to metaphysis, there are vascular loops. Now, when you have a loop, it's like a road. If you have a straight road, you can press gas and forget about, the speed limit, I guess, and you just go straight. No problem. That's laminar flow. No impedance, no obstruction. But if you have turns in the road, corners, and loops that you have to go around, now the well-thinking driver should slow down, right? Some of you probably don't, but you ought to slow down when you're approaching a turn, lest you end up in a wall. And so when you slow down, you're creating more of a turbulence. And so it's the same thing as you approach the metaphyseal region. So the blood is flowing. Once it reaches the vascular loops, it's slowing down. Now, the organisms, the bacteria in the blood, appreciates this change in velocity because it allows the bacteria now to come off. Like, stop here, driver. This is my stop. I'm coming off now. It squeezes through some gaps in the endothelium and adheres to the bone itself. So now it's setting up shop and it proliferates, and then you have an established infection. So it's adhering to the type 1 collagen, and there's increased pressures in bone as the organism multiplies, proliferates. Post-formation, it would be the dead debris from the inflammatory cells, the bacterial elements, and so that inflammatory / infected milieu that's forming there would be that purulent material that would form over time we call pus. As it forms, it's space occupying, but bone won't accommodate the pus. So the pressures within the bone are increased. We call it intraosseous hypertension. Over time, it will find a way to decompress itself. That's when you have a breach in the cortex because the pus is trying to get out of the bone. Right next to the bone, as we said, on the outside would be your periosteum. And so next to the periosteum, the membranous portion, you form a collection of pus we call the subperiosteal collection. Subperiosteal collection. If it goes further through the periosteum, then you may form a soft tissue abscess adjacent to the bone on the opposite side. That's the fibrous portion of the periosteum. And then it would make its way through a tract that it's creating. The pressure head would be pushing through the soft tissues until it ends up on the outside. And then a few days later, you have pus draining from the limb, then you have to be thinking, is this a deeper infection in the bone? Now I have here, it may spread to the joint. Now when we say it spreads to the joint, in a younger kids, there is a direct communication between the metaphysis and the epiphysis. Are you still hearing me?
Yes,
Are we
yes,
still
doc.
hearing? Okay, good. So between the epiphysis and the metaphysis, the blood vessels traverse the physis. But after about 18 months, this is no longer so. So the metaphyseal vessels are separate from the epiphyseal vessels. But as long as the blood vessels traverse the physis in the early stages of development, then you can then appreciate that bacteria can move from the metaphyseal region where the infection is into the epiphyseal region. We also know that the epiphysis is the end of a long bone that communicates with another bone to form a joint. That's the epiphyseal region. So if the epiphysis becomes infected, you can then easily see how it can spread to the joint. The other problem is in the young child, developing child, the capsule encompasses the metaphyseal region until it elongates and encapsulating the epiphyseal region. But at some point in time, the metaphyseal region, the capsule is further down. So you can have vessels going across the physis, but the older child, the physis becomes a physical barrier to infection, and that's why adults tend not to present with infection. So if you look at the middle picture, you notice that the capsule comes all the way down, and so infection can traverse into the joint or through the vessels that go through the epiphysis and end up in the joint if this is severely infected, the epiphysis of the long bone. Over time, it's no longer communicating, and so the infection may stay in the metaphyseal region and continue down the diaphysis because there's no physical barrier. So how do they present? Now we're going to spend the rest of the time looking at the parameter of time. So we're looking at acute versus chronic osteomyelitis. We tend not to discuss too much with you the subacute picture because it presents in a totally different fashion. A lot of times they're actually presented as an incidental finding because it's subacute, tend not to have florid signs and symptoms. And so we tend not to discuss that at the junior level because the management is quite different from acute versus chronic. Even the organisms that are implicated in subacute, they tend not to be too virulent, and that's why you have a subclinical picture. The parameters of time, we talk about acute, we're usually looking at a time frame of 6 weeks or less. So less than 6 weeks. Chronic osteomyelitis, we're looking at greater than 3 months. So you then say, what is subacute? Subacute is somewhere in between, but it's very difficult. So there's no magic figure. So after six weeks, you don't cross over from acute to chronic. It's not that sort of a transition because you can completely treat acute osteomyelitis. You can have recurrence, or you can have prolonged acute phase transitioning to chronic osteomyelitis in the smaller number of patients. So that's why I said the parameter of time is a gray area because it's not well defined in terms of absolute time frames. But we do use a cutoff of 6 weeks. So if the history and examination indicates less than 6 weeks, we call that acute, and greater than 3 months, we're definitely into the chronic phase of osteomyelitis. In the acute phase, the patients are ill looking. They tend to present and they are unwell. In the very young child, you may have pseudoparalysis. If it's a weight-bearing joint, there may be non-weight bearing. And the patient comes in, mommy or daddy, usually mommy, complains that the patient is not using the limb. Not that they can't use the limb, but they don't want to use the limb. And usually, because they can't talk, it's painful. They don't want to use the limb, and so they end up with with um, favoring the other side, even if it's a non-dominant side of the patient. And the neonates, they just stop using the limb. Looks like it's paralyzed. We call that pseudoparalysis because it's really not a neurological problem. Fever. Fever, lethargy, anorexia, vomiting, nausea, everything causes the child to vomit. Right? If they're happy, they vomit. If they're sad, they vomit. If they're upset, if they're in pain, they vomit. So nausea in the older child, you can say that they're nauseous, but vomiting, anorexia, not wanting to eat, all of this would be a systemic manifestation of infection, inflammation. So fever is the body's response to maybe a bacteremia or a viremia. Remember, in these children, the commonest cause is hematogenous in terms of mode of transmission. So the fever is a response to probably the bacteria in the blood, a bacteremia, and so the fever is present. And it's the fever, it's the systemic response that gives the lethargy and the anorexia and the failure to move around. They're very listless. And so they present looking ill. These are the patients you don't want to send home. Swelling in the area of concern, and that clues you in that something locally is happening that's probably manifesting as um, systemic response. Now, you can have remote areas of infection, and that's usually how you get the bacteremia or viremia. So commonly, these patients have infections in the chest or a urinary tract infection. And then they seed in the blood to those areas of bone, because bone is sterile, and then it sets up a picture for osteomyelitis. In the chronic stage, when they present, usually the adults, they're well looking. They're not coming in with fever and those unless it's acute on chronic. When they come in with chronic presentations, it's more localized. So they come pointing to a specific area. So they have pain at the site, and you may actually pick up chronic skin changes. They may offer to you that this has been a problem for X number of months or years. They may have deformity. The deformity may just be the infection itself, deforming the bone, because you do have changes in the bone and the architecture, the laying down of new bone, the resorption of dead bone and those things, or you may have a pathological fracture. So that may create instability and deformity immediately. So you have loss of function. If you see heel or draining sinuses, you're not dealing with an acute picture. It doesn't happen overnight. So it takes time to develop a sinus based on the pathogenesis that we just went through. And if you see that, you know you're dealing with something that is chronic. How do we investigate them? Nothing specific per se, but what we're looking for is to diagnose an infection and try to pinpoint it to an actual site, the bone. So in the blood, we want complete blood count and a white blood cell with differentials. Commonly, it's a bacterial agent, and so therefore we're looking for a leukocytosis, certainly in the acute setting, and more importantly, a neutrophilia. So you can have a leftward shift on your graft. Neutrophilia, that would go up with bacterial infections, right? The ESR, what's that? What is ESR? Anybody, what is ESR?
Erythrocyte sedimentary rate.
Erythrocyte sedimentation rate. So it's a rate. What is it measuring?
Rouleau formation.
not necessarily ruler formation. Ruler formation is a specific term used for certain conditions. As the name suggests, is a sedimentation, but it's influenced by fibrinogen. We're looking at how fast the red cells pretty much sediment fall to the bottom. So it's left to stand, and we're looking at the rate of fall. Now, what is the normal ESR that is expected in a normal population? What is normal ESR? How do you know that the ESR is abnormal? What's normal? About 10 to 20, about 10 to 15, yeah, but if you carry it to 20, it's a little high, but 12 to 15, yes, that's a little better. But certainly, what I want you to say first and foremost is that it's dependent on your gender. So the females are a little higher, and that's why there's a range, because in the males, 15 and 20 would be considered high. The males tend to be more, at most, maybe 10 or less. So the males are a little lower than females. Females, because of estrogen and menstruation and those things, they have a little bit of a difference in physiology, and so the erythrocyte sedimentation rate is actually higher in females. Then you would see the ESR is also influenced by age, because as we get older, your ESR, the allowable limit, increases as well. So it's not uncommon to have an 80-year-old female with an ESR of 30. That may actually be her baseline. So with a young patient, we're not looking at 30 as normal. That's elevated whether you're male or female. So there are parameters that we use, but the ballpark figure, about 12, 15, that's pretty much correct. And it's millimeters per hour, because that's a rate. It's a rate. All right? The CRP, what's that? CRP. What is that? C-reactive protein. That's correct. Where is it being produced? Where is the CRP coming from? The liver. So the liver produces the CRP as an acute phase reactant protein in the face of infection or inflammation. It's an inflammatory marker. We call it a biochemical marker. So both the ESR and CRP are biochemical markers for infection or inflammation. So they're not specific. However, in the face of osteomyelitis, both the ESR and CRP in the acute setting is significantly elevated. And that's why I asked about the normal value. What's the normal CRP? What's normal CRP? Again, it really depends on the lab in which it's done. So the units are important. 10 what? Milligrams per liter. Yes, so milligrams per liter, or so with respect to the CRP done at different labs, you can have milligrams per liter, which is SI unit, or the conventional units, you can have micrograms per milliliter. But irrespective of which lab you do it in, it should be less than, you would see less than 1, less than 0.5, less than 0.2, less than 1.2. Some would present it as a ratio. But the CRP in acute osteomyelitis, again, is significantly elevated. So if you're having values less than 1, your CRP of 20 and 30 is significantly elevated. ESRs in acute setting would be higher than 80, 90, sometimes over 100. Some labs stop counting at 130. So you know it's not something that you you're wondering if you have some sort of infection on board. It's not 22. When you see an ESR of 30 in the face of osteomyelitis, that's probably a chronic picture that's no longer acute. So we're dealing with significantly marked elevations of CRP ESR. If both are elevated, it's a stronger case for your condition. The CRP rises faster and falls faster than the ESR. We follow these as biochemical markers for the management of the patient. The white cell is increased in up to 40% of patients. We talk about that left shift. So you can see here, within a couple of hours, your CRP is elevated in 97% of patients. The ESR follows shortly after, but certainly within a day or two, you would have both being increased significantly. Blood cultures. Yes, you can do a blood culture, certainly in the acute setting. That gives you positive yield, mostly in the patients that are presenting with a fever. And it's the uptick of the fever that will give you the highest yield, because this indicates that something is happening, a systemic response, usually the bacteremia. And that's where you would catch the organism when you do that blood culture. But if they're afebrile, well looking, it's localized, it's chronic, blood cultures then fall off to less than 20%. Bone aspirate. The young child, yes, you can get a needle through the bone. We can go in, aspirate the soft tissues around, just to ensure it's not a soft tissue collection. And as we penetrate the cortex of the bone, we aspirate the bone, send it off for cultures. If you get a positive yield, then you're definitely dealing with osteomyelitis, because the bone is sterile, and we get positive cultures in about 70% of these patients. Gram stain in about a third of bone and joint aspirates. It would tell you if you're gram positive or negative. Usually they're positive because we're dealing with staph most of the time. Radiology, nothing specific. We do the usual ultrasound, bone scan, CT scans, MRIs, but the ultrasound of note is very user dependent. But it's useful in the young child where the bone is developing. So there's a lot of cartilage, soft tissue around, and you can pick up easily collections, because that's what the ultrasound is good at, soft tissue and fluid. So with the subperiosteal collections, abscesses, joint effusions, the ultrasound is pretty good, very good in the pediatric population. As you get older, it sort of falls off in terms of helpfulness. X-rays, not very sensitive and not 100% specific, but it is helpful. Of note, your x-rays, if done very early in the course of osteomyelitis, may actually appear normal, but it's a baseline because you can repeat it. Here, in this picture, you can see some radiolucency here. That's focal osteopenia. Something is happening here at the metaphyseal region. We're suspicious of osteomyelitis. However, there are a number of things that you can look out for on the x-rays. First of all, you may see nothing, so it looks normal. Doesn't rule out osteomyelitis, it just means that it may be a bit early, because the radiographic picture, radiological picture, lags behind by about 10 to 14 days behind the clinical picture. So if it's a 6-day history, you may actually see a normal x-ray. You may see increased soft tissue shadows. You see the fascial planes quite clearly within about 2-3 days, and that suggests that there's fluid around inflammation, infection, causing swelling of the soft tissues. Periosteal reaction, you only see that about 5 to 7 days later. We spoke about focal osteopenia, and then you start seeing osteolysis. Now, the focal osteopenia and osteolysis, you see that 10 days to 2 weeks after the infective picture. And that's because it takes about 2 weeks for you to lose 50% of the bone mineral density with a lytic lesion, and it's only then will you see a lytic lesion or osteopenia on an X-ray. So earlier than that, you may actually see nothing. So this is what we call that hazy line on the outside and probably up here. This is what we call periosteal reaction. Remember, the periosteum is soft tissue. And so you cannot say the periosteum in and of itself, but this is new bone. because the periosteum is reacting to something happening in the bone. And you see how it looks a little sclerotic. The canal is very narrowed, and then the cortex here is narrowed compared to here. When you look at the other bone, you have a nice uniformed canal. Something is definitely going on with this bone. And so here in the ulna, we're looking at a periostal reaction to something happening here, more than likely osteomyelitis. With chronic osteomyelitis, you may see sclerotic lesions, radiolucent lesions, pathological fractures, the remodeling of bone, Codman's triangle, not specific to osteomyelitis. You can also see it in malignancies. It just speaks to the aggressive nature of what's happening. Sequestrum and involucrum are highlighted. Now, sequestrum, by definition, is that island of dead bone. It's dead bone surrounded by an island of pus. So, sequestrum is a hallmark feature of chronic osteomyelitis, not acute. Involucrum is the opposite. It's new bone that's being deposited in the face of chronicity, chronic infection. So the new bone is trying to replace the old bone. So the old bone, where the blood vessels and everything would be destroyed, the bone dies, it becomes brittle. I think I lost you guys for a bit there. So this slide is showing features of chronic osteomyelitis, and that's sclerotic lesions, radiolucent lesions, pathological fractures. Now, highlighted here would be sequestrum and involucrum. I was saying that involucrum would be new bone deposition in the face of chronic infection, whereas sequestrum would be dead bone surrounded by an island of pus. These two together are hallmark features of chronic osteomyelitis. So if you see sequestrum or involucrum in the face of infection, it is not acute osteomyelitis. This does not happen overnight. This takes time, certainly beyond 3 months. As I said, Codman's triangle can be seen with an aggressive lesion in malignancy, not specific to osteomyelitis, but in chronic osteomyelitis, if it's active, you can certainly see a Codman's triangle as well. That's a radiographic feature. So this is a picture of involucrum, that beefy red bleeding bone. That's new bone being deposited, whereas this ivory white bone lacking blood supply would be your sequestrum. So this ivory white bone, sequestrum, nice bleeding bone, that's involucrum, that's new bone being deposited. All of this would be separate and apart from the native bone. This would have been the native bone initially, but it's dead now, and so the body is now reacting to it, the periostal reaction, mature bone now trying to replace this dead bone. This dead bone becomes a nidus for infection, and so in chronic stages, this needs to be removed. Otherwise, it just stays there, and this is where the bacteria would live and proliferate. Not in this one, usually. It's in the dead bone, because there's no blood supply. So on radiographs, you see that bone-in-bone appearance. So on the inside, this is sequestrum. All of this is dead bone. And you have a pathological fracture on the proximal aspect of it, because it has weakened the bone completely. So dead bone is brittle, and it would fail on the load. When we do a nuclear scan, a bone scan, we're looking for increased activity, and you can see in the little finger on the right that there is increased activity evidenced by more uptake, and that would clue you into something happening. We try to enhance the bone scan by doing a number of things, gallium, or labeling the radioactive isotope with leukocytes, or even using monoclonal antibodies to organisms, trying to find the uptake or enhance the uptake in bone scans to get a better yield. CT scans for the complex areas like the pelvis may show you that something is happening with the bone here. You can see the ramus on the left, and associated with it you have this area of this hypodense area, the crease signal, and so that's gas. So it's a gas forming organism with a bit of sequestrum in there. So you have osteomyelitis of the pelvis. MRI, very sensitive and specific, but what's important to note is that your differentials in MRI, you should entertain, because they all look similar, and infection mimics in tumors. So when you see these changes, it could be osteomyelitis, or it could be a fracture, an infarct, bone bruising, tumor, post-surgical changes. So this must correlate with the clinical picture, how the patient presented, if they had any procedures done, and on the background of that, it's increasing your suspicion for osteomyelitis. You can see increased signal changes in the distal tibia. Are we dealing with chronic osteomyelitis, or is it one of these? So the MRI, although sensitive, is not very specific to tell you exactly what it is. I don't need you to learn this criteria. This is just showing you that we do use different criteria to increase our suspicion and diagnose osteomyelitis in orthopedics. They exist. So it's not a guessing game. How do we treat these patients? So with acute osteomyelitis, we admit all these patients. If we're diagnosing osteomyelitis, that's acute, less than 6 weeks, we admit these patients because we want to start parenteral antibiotics, broad spectrum empirical antibiotics covering common organisms. We just said about Staph aureus, so we want to cover gram-positive organisms. So we use empirical broad spectrum antibiotics, usually a cephalosporin, second generation, first and second generation. Sometimes you see us using a third generation, and that's just based on availability. Sometimes the good old augmentin is actually useful because a lot of our Staph aureus is not MRSA, it's MSSA, so it's methicillin sensitive, and they're still sensitive in Jamaica to augmentin. So you see us giving clavulanic acid, amoxicillin. Compliance is essential, and that's why we admit them. If we admit them, they're under our control. We can give them parenteral antibiotics. I have here combined with oral combinations, but this is after your monitoring. So the antibiotic duration is for 6 weeks, but we are following these parameters. One, we have identified the organism from our cultures, so we now have them on culture-directed antibiotics. We have isolated the sensitivity of that isolate. We are following the biochemical markers, and if they're trending down, the patient is no longer febrile, they're eating, they're playing, white cell is coming down, and then after 2 weeks of parenteral antibiotics, we can then switch them to oral antibiotics, still following these, and they continue to trend downwards. We can discharge this patient to continue the antibiotics as an oral prep for the remaining weeks. So we want a total of 6 weeks. We don't want to treat this suboptimally because you can then have surges of resistance, and that's what we don't want. So we want 6 weeks completed antibiotics, but you can switch them to oral only after you have followed the parameters. They're improving after 2 weeks. That way you cut down on time in a hospital, and that has socioeconomic implications. It's a win-win situation, as long as you can guarantee compliance. Surgery in the face of acute osteomyelitis is limited. We do it in specific scenarios, and what we want to really do is improve the local environment by removing not necessarily the vitalized bone, but certainly infected tissue and decompressing abscess cavities. So it's less frequent now that we have antibiotic therapy where we can treat them completely with our antibiotics. So we indicate surgery is indicated when you have collection, wherever it is, or the patient is not responding to your clinical therapy. So you're putting them on the culture-directed antibiotics, but the bacterial load is just too much. And so sometimes we have to go in and decrease that bacterial load and infected tissue. If there's an associated septic arthritis, we definitely want to wash that joint out. So that's not osteomyelitis. We need to get rid of that infected picture in the joint itself because it destroys the cartilage very quickly. And the time frame in terms of failure to improve, we're talking 2 to 3 days, not a week. A week is when we're monitoring the markers and they're going down and everybody is happy. We can repeat ESR CRP once a week, not every day, once a week. So at surgery, we may aspirate, incise, drain the soft tissue abscess. We drill holes in the bone and evacuate the pus. We irrigate the canal through and through. We may leave suction drains inside it and then remove them once we're happy that we're not draining pus any longer. For the chronic osteomyelitis, rather than putting the patient on the ward, sometimes we can manage these patients as an outpatient as long as we don't have a surgical indication, but oftentimes with sequestrum, surgery is involved. So oftentimes we have to operate on these patients if we're going to get control over this infection. And that is to excise dead bone. That's the sequestrum. While there, we're trying to remove all dead and devitalized tissue. We nibble the bone back until we see healthy bleeding bone, punctate bleeding from the bone edges is an indication of healthy bone. We irrigate and then we may insert antibiotic impregnated beads. These are polymers of polymethyl methacrylate with antibiotics in them, usually an aminoglycoside, and that's because they're heat stable and they withstand the formation of beads which result in heat. It's an exothermic reaction when preparing the beads, and so they do have good bone penetration and they cover the common organisms. So you may see us using gentamicin impregnated antibiotic beads. We put them inside, and then the downside is that we have to go back for them. Because after the antibiotics have been leached out into the soft tissues and bone, then they become a foreign body. So we have to remove them because they don't break down. You do have beads that can break down, but sometimes they're not available. Your primary goal is to get rid of infection. This may actually destabilize the bone. So oftentimes we have to stabilize the bone with an external fixator. This is a picture that's not sequestrum, that is actually antibiotic impregnated beads on a wire for ease of removal. We count the beads. Sometimes we're using beads up to 120 beads in one patient. So it's important that we remove all of them when we go back so as not to create a picture for prolonged infection. As we said, some areas of the bone are very difficult to treat, like calcaneus, pelvis, vertebra, and so they require longer periods of management, sometimes 3 months, sometimes 6 months. So you have them on prolonged courses of suppressive therapy, trying to treat this or eradicate infection in these problematic areas. What are the complications? They're myriad. You can have recurrence in the acute setting. You can have chronic osteomyelitis. If it's near to the metaphyseal region, you can affect the growth plate, resulting in limb length discrepancies. You can have angular deformities. In the acute setting, you can definitely have febrile seizures, septicemia, septic embolization. In subacute picture, which we really didn't discuss, we can have abscess formation. They're not necessarily painful. A Brody's abscess highlighted here is simply a hole in the bone that probably has granulation tissue that's infected in that area. So infected material would be in that bone. This may be an incidental finding doing x-rays for some other reason and recognizing that there's something happening here. But you can see that this is benign and it's been there for a long time based on that sclerotic rim. So this has been there long enough to allow the bone to respond to this lesion. And that tells us that something has been there, but it has been there for a long time. So this is what the Brody's abscess look like. We tend to see this not in acute, not in chronic, but subacute. The organisms aren't very virulent, and so it's a very low-grade, smoldering sort of infection, and that's why the patients are pretty much well and okay with subacute. Chronic osteomyelitis, you may have avascular necrosis of that epiphyseal region, certainly the femoral head, humeral head, sinus tract formation. Now, if you have prolonged inflammatory markers just hanging around, you can have mutations. And that's what we have to look out for, because you can have transformation, malignant transformation into any one of these when it comes to osteomyelitis. So it's not necessarily always a benign procedure, a benign condition. Sometimes you may have that sinister patient with chronic osteomyelitis not getting any better no matter what you do. You have to be suspicious. Are we undergoing a transformation here? Are we dealing with a malignancy within chronic osteomyelitis? And so in orthopedics, we operate under the guide, we biopsy all infections and we culture all malignancies. We biopsy all infections and we culture all malignancies, because infection, chronic osteomyelitis, is the great mimicker of conditions, including cancers. Limb length inequality, angular deformities, as I said, osteoarthritis, because it's destroying the joint, pathological fractures, all having significant implications. Now, we have looked at all of the physical problems that can go wrong, but I want to highlight that time away from home and school, you have loss of education, the increased cost of medications, prolonged medication, loss of resources. Oftentimes, these patients may have loss of function of your limb for a very long time. And added to multiple admissions, multiple operations, psychologically, they may be depressed. Unfortunately, a significant number of them may actually lead a life of poverty. And I think that is something that we have to address. Recognizing very early that intervention may actually be needed to mitigate these psychosocial issues when it comes to chronic osteomyelitis. What I want to highlight here before we wrap up is the subcategory of the sickler. So with HBSS disease and osteomyelitis, it's more of a diagnostic dilemma. We have nothing specific to diagnose osteomyelitis, but the sickler presents a specific challenge in that the underlying condition, sickle cell disease, you have multiple infarcts and vaso-occlusive crises with occlusion of vessels. So oftentimes they may present with bone pain. You're not sure if it's infection or not. But a tumor, a bony infarct is painful, but a bony infarct is also dead bone. So the blood supply is lacking and you have an infarct in bone, like a myocardial infarction. The same thing happens in bone. The blood supply is cut off, is decreased, and the bone that it supplies dies. That's called a bony infarct, separate from sequestrum, because we said sequestrum is dead bone as well. But that's surrounded by an island of pus. That's in the face of chronic osteomyelitis. If there's no infection, and for whatever reason your blood supply is cut off, let's say a neck or femur fracture that's intracapsular, you can have avascular necrosis of the head of the femur. That's dead bone as well. But it's not a bony infarct. It's not sequestrum. It's called avascular necrosis. So that's why I said different scenarios, we give different names to dead bone in orthopedics. So with the sickler, the infection may actually be preceded by bony infarct, which sets up a picture for the nidus for infection. So when you have an infarcted bone, dead bone, this is where the bacteria now seeds to, because there's no blood supply. That's exactly what it wants, to hide away from the immune system, and then it starts to proliferate and infect the bone. It may be diaphyseal because of the paucity of blood supply to the bones. The long bones, where the diaphysis is basically supplied by the nutrient arteries. So there are no lot, there aren't sinusoids and collaterals like metaphyseal and epiphyseal region. So they have diaphyseal osteomyelitis, polyostotic because it's a systemic condition, so you have it on either side. So it may be symmetrical. They may be coming in with bilateral thigh pain. And so you're always left with, is it infection versus infarction? There's a higher incidence of osteomyelitis caused by Salmonella species. Salmonella species. And it's not because the sicklers have more Salmonella than you and I. We all have Salmonella. But the fact that they can't get rid of encapsulated organisms like we do, Salmonella is an encapsulated organism. With the Salmonella presenting in the gut is not spared from microinfarction. So when you have microinfarcts in the sickler, in the gut, it allows the Salmonella to translocate quite easily, enter the bloodstream, and then, without a spleen, they are not able to get rid of it. And so the Salmonella may cause infection, whereas in persons like yourself, without sickle cell disease, they're able to fight the Salmonella species. Having said that, the commonest organism that creates osteomyelitis in sicklers, for the most part, is still Staph aureus. What I'm saying is that there's a higher incidence of osteomyelitis caused by Salmonella. Now, having said this, of note, certain parts of the world, Salmonella is the commonest cause. So if you look, it depends on where you're looking. When you're reading, it depends on where you're looking. So maybe in the US, they may say Salmonella. Parts of Africa, they may say Staph aureus. So it depends on the literature that you're reading in terms of what is the commonest organism for osteomyelitis. I think in Jamaica, it's still Staph aureus. What is accepted, though, is that there's a higher incidence of osteomyelitis caused by Salmonella species in the sickle cell disease population. All right. So I think we'll stop here. Any further questions? Any questions that you'd like to ask? If you don't have them immediately, you can think about it. Now, I encourage reading because repetition drives learning. And once you come up with anything that you need to clarify, you can always touch base with myself, Dr. Palmer. You can send it on OUR VLE and we can address it in a timely fashion so that you understand and you have a good foundation to the condition infection in bone we call osteomyelitis going forward. Any questions? Well, if there are no questions, I'd like to thank you guys. And you continue reading, continue being safe, following the protocols and guidelines by the Ministry of Health and Wellness. And we'll catch up sometime in terms of smaller tutorials and just teaching and discussing different topics in orthopedics. Again, welcome to orthopedics and enjoy the rest of your day. Thank you.